Assalamu alaikum wa rahmatullah, and good evening, everyone. With you is Dr. Abi Zubaydi, cardiologist here in Abu Dhabi, and I'm honored tonight to chair this session with two experts in the field of lipids. This is a part of a series of mastering the management of hyperlipidemia for high risk and very high risk atherosclerosis and vascular disease patients. This series are addressing lipids, helping us as experts dealing with patients with hyperlipidemia in terms of diagnosing and identifying the risk and the best treatment approach for these patients. Tonight, as I said, we have two experts who are going to share with us their expertise in this area and up to date on the treatment of hyperlipidemia. The first talk is going to be by Dr. Rad Nari, which is going to be leaving no stone unturned in the lipids management. Dr. Rad is a consultant in internal medicine, and he's one of Imperial College London Diabetes Center leading expert in the management of diabetes, with a focus on tough population, the elderly patients. He has also notched up an extensive award-winning career managing cases involving cerebrovascular disease, stroke, movement disorders, and dementia. Over many years in the UK, Dr. Nari led various specialist research teams, as well as numerous departments specializing in stroke and relating issues. He was part of, as I said, of multiple studies and trials. His most recent achievement includes a distinction award in master's degree in diabetes from the UK for his research work on sodium glucose transporters, SGLT2 inhibitors. So a long list of achievement. Dr. Rad will go direct to I think to your talk and to untturn all the stones. Tfadal, Dr. Rad.
Yeah, thank you very much, Dr. Abdel Majid, for your generous introduction. And without any delay, I would like just to share my screen now with the audience as well. And thanks for the audience for sparing their time this evening to come and listen to this talk about dyslipidemia, which is a subject dear to my heart, which I continue to learn every day new information. And also this will be followed by my colleague, Dr. Hani Sabur, who will also will be benefiting all of us from his experience and the management. So the title of the talk, I'll go quickly because I want you to achieve the maximum benefit from my talk. I titled Leaving No Stone Unturned, but of course, lipids is a very dense subject and it needs a lot of time. But what I would like you to do, especially in the first part, I would like you to concentrate because to understand lipids, you have to understand the basics. So the essence of my talk is going to some of the basics. I will give you practice pearls, reflecting evidence into practice. I'll share with you also some pictorial reviews, and then I'll bring you to what's new in the field of lipidology. And it's always a mutual learning process. So it's exactly like boarding a flight. So we need a thrust to lift off, and then we'll get airborne, we'll enjoy the session. It can get bumpy at some times, so I need your concentration, but I'll promise will land you safely with a lot of information. So as you know, the pathology of atherosclerosis is very complicated. There was this data published in the European Heart Journal for a 10-year-old boy with myocardial infarction and LDL of 800. plus. So you can see here the atheroma that happens with atherosclerotic heart disease. And what we are interested, and I'm sure Dr. Hani agrees, that there is what we call the unstable plaque. There is more lumen, but there is a very thin cusp, and there is a lot of big core for the plaque, and this makes them very easy to detach and cause problems. So this is what happens. I call it the shearing force. So the shearing force is very important because whatever you have, high blood pressure, glucose toxicity, very high LDL, this will promote injury to the endothelium. And then your LDL, these yellow small dots will get into the subendothelial. And then there will be formation, what we call a foam macrophage, because the macrophage will consider it as an invader. And then they will go inside the cells and trigger inflammatory process, fibrin degradation products, platelet adhesion molecules, atheroma, calcium deposition, atherosclerosis. So that's what we don't want to happen for our cells. And this is, you can see here at the lower panel, is a dirty fibrofatty plaque extracted from the carotid artery in a patient with significant dyslipidemia. So our aim as physicians is try to prevent this from happening to our patients and intervene early. Now, carotid intima thickness is a very gold standard to do as well for our patients in order to stratify their risk, or we call them aggregation risk factors. And this is a very useful non-invasive study, can be done by your local cardiologist. And it's important to do that in stratification of risk of borderline cases. The same applies to coronary calcium, which I'm sure Dr. Hani will touch base on it, but the carotid intima is more specific than the coronary calcium. So coronary calcium, very, very useful for cases in which you have a cardiovascular risk between 5% to less than 20%, and you want to see whether they need treatment or not. Generally, values of a 100 needs the initiation of a statin therapy. Some patients could be asymptomatic, but you suspect because of family history of other symptoms, changes on a treadmill, then you have to do this, and you can see here the dense plaque. So this patient is a very high risk, and you need to be aggressively treating him. So this is what happens, what we call the lipoproteins. So in the core of the lipoprotein lies your cholesterol esters, and at the outer surface is the free cholesterol, and inside there is the free fatty acids triglycerol. And we have ApoE and ApoC attached at the surface. The reason why they are at the surface is that they are useful in docking to different types of cells, like adipose tissue or the liver. Now, when I was wanted to know about lipids, what I started to do is read in textbook, and I became very confused. So I tried to simplify things by myself. So this is basically the apoprotein. It has integral phospholipid, and inside the cholesterol esters, and it has integral protein here, which could be either ApoE or ApoB, and peripheral protein could be either ApoC or ApoE. So for example, let's take an example. For kilomicrons, there is about 88% of the composition is triglycerides and less as a protein. Now, as you move right to the low density, you can see here the cholesterol esters is 48% and triglycerides is lower. The intermediate density is about equidistant. And the VLDL carries more triglyceride than cholesterol esters. It's an important concept for you to understand because that can have an impact on the pathology. So after this meeting, after 9 p.m. tonight, if you're going to eat something, the chunk of food goes into your stomach, then the intestine, and then the fat will be absorbed, and you get what we call ApoB48. Now the ApoE goes to the liver, and the ApoC goes to the adipose tissue, and in the adipose tissue, you actually transfer the triglycerides to the adipose tissue, and by this way, you get recycling of fat inside the body. Now, the liver is actually the organ for forming the VLDL, which goes, a lot of molecules have high triglycerides in them, and they have the ApoB100. So ApoB100 is unique to VLDL and LDL, and even the intermediate density. And the same cycle here through the ApoC, you get docking into your liver, adipose tissue, and you transform the triglyceride. Now, I mentioned here in orange MPTP. This is a microsomal transfer protein that is found in the endoplasmic reticulum of the liver. Now, I'd like you to keep this in my mind. I'll come back to it later at the end of the session. So as you lose triglycerides, the size of your LDL will become less. It will become IDL because you lose triglycerides. And you lose more triglycerides, you form the low-density lipoprotein and then circle back to the liver. Now, I just like to mention, it's a misnomer to say that cholesterol is bad for you, because cholesterol is part of every single cell in our body. It forms part of our immune system and a precursor for many hormones. But high LDL is bad for you. Now, on the other hand, ApoA1, which is formed from the liver, is actually protective. So it's an empty sac. It doesn't have like what the other molecules I showed you, apoprotein. And through an enzyme, which I circled, I'll tell you why at the end, it's called lecithin cholesterol alkyl transferase. It comes to the cell surface and sucks out the cholesterol esters. So this is the good guy. It's like a postman. It collects your cholesterol ester and gets it back to the liver for digestion. So here also I put in, it's called ABCA cassette. I'll mention that to the end. So this is the process of forming HDL. Now, for us as physicians, any patients we see in the clinic tomorrow, we have to stratify what we call the atherothrombosis risk stratification. So the more points you have these, it means the intensification of treatment should be more. History of smoking, renal dysfunction, CKD, prior CABG, stroke, diabetes, age above 75, hypertension, and so forth. And based on that, there will be, I think it will be better for us in the future to go what we call through the cardiometabolic clinic, which is a one-stop clinic that all the patients can attend. Now, historically, LDL been very popular. Initially, we said the LDL is very bad, and we didn't know what to do about it. Then we said average LDL is good, then low LDL is good, then lower LDL is good, and then I don't know what's coming next. So we are changing, but we are also now not focusing only on LDL, but we are also focusing on LDL particle fractionation size. So not only the absolute number, but the size matters, and also non-HDL is very important, another risk factor. So if a patient comes to your clinic, asks you, what is my normal lipid profile? It's difficult, but these are general rules of thumb. So your total cholesterol, 135 to 200, if you change it, you multiply it by 38.67, and LDL generally 130 if you don't have any risk factors, but more recently we should follow the guidance which was released. HDL is important, is around 1, and triglycerides should be below 150, but here the correction factor is multiplied by 88.57, and the 38 is for cholesterol. So this is basic mathematics for you. LDL equals total cholesterol minus high HDL minus triglycerides over 5. And you all remember from biochemistry, from the Friedwald equation, you can apply it, but we cannot use it if our triglycerides is above 400 because it will be erroneous. Also in the UK, they use total cholesterol over HDL ratio. The optimal is 5, ideal is 3.5. Why? Because if your total cholesterol is normal, your HDL is low, your risk will go higher. So you need optimization. Non-HDL, which is very important aspect, is total cholesterol minus your HDL. And to achieve a target, you just add 30 to the LDL value of target. ApoB target, so this is new. Some of the labs in high-risk patients, they do ApoB estimation. It should be less than 80 in very high risk and less than 90 in high-risk patients. Also, this is the biochemical pathway for EPA and DHA, which is eicosapentaenoic acid and doxohexaenoic acid, which forms the treatment for triglycerides. And it all stems up from alpha-linoleic acid and the difference between 3-carbon and 6-carbon omega atoms. So the patient come and ask you tomorrow as a practice bill for you. He says, what is my risk, doctor? First of all, there is no fatigue in guidelines, but we should use common sense complemented with the risk calculators that we have recently. And we should treat patients and figures, not figures alone. And we have to have active lateral thinking process, thinking about the pros and cons, and we should know our stuff well. So we should know our pharmacology well. So you see this rusted bus, it's actually, it's the process of atherosclerosis. So some of us might be brewing atherosclerosis without obvious signs, but suddenly, bang, you get a puncture and you get an event, whether a stroke or myocardial infarction or even death. So our duty from now is to prevent the rusting process from taking place, because we know for sure that the higher risk, if you are diabetic or you get aggregate risk factor, your cardiovascular events will increase exponentially, no doubt about that. So we should stratify the risk. LDL is the main driver, and LDL has been very popular in epidemiological studies, research, genetics, therapy, and also experimental. But if you reduce your LDL by 1 millimole, or you reduce your blood pressure by 10 millimeters mercury, as published in the Lancet, you actually have a 22% relative risk reduction in events. And there are many equations you can use. All of them are similar. In the United States, they use the Ascvd pooled risk cohort equation. So you just enter the data here and you whiz through it and it will tell you what is your risk. In our center, we still use the Framingham 10-year risk calculator. It's good. It can give you a rough idea about what's going on. And in the UK, most general practitioners use the QRisk2 calculator. And I put here the risk, the link for you. Try it on yourself and see what is your QRisk accounts for. And also in the United States, they use cvriskcalculator.com, which includes also your blood pressure and other risk factors like diabetes and smoking. And I like to add for you what is called the Reynolds risk score. The reason I put Reynolds risk score, this is actually for non-diabetic patients, but it can predict your future having a heart attack or a stroke. But what they have here is they have the high sensitive CRP. So CRP is independent risk factor that can actually aggregate risk factor, especially if it's above 2 milligrams. It becomes aggregate risk factor. So lipid management is complex, and we have to define when to start therapy, which patient is should be targeted, and who, why, etc. So no trials can show a specific target. However, now we use what we call risks. So, and also we have to think that does 50% lowering of your LDL gets you to the target, and if then what you should do, whether you should use intensifying therapy with other agents, because I'll tell you, we are lucky in this time or this era because we have a plethora of medications that are useful to be used in our patients. Previously, even statins didn't exist. Okay, so it was just diet modification. Now, I like to mind you, for those who travel in the underground in the UK, they know what I mean by mind the gap. And this study, which was actually done in the Gulf and the Middle East and in UAE, it shows that nearly 2/3 of patients treated for ACS did not achieve their LDL target despite while receiving primarily moderate intensity therapy. So 3.7% were not taking the lipid lower therapy 4 months after the ACS events. So this is called DICES-2, and this highlights to us the importance of looking after these patients at an early stage. There are many guidelines, but all of them, they point to the same. So I just want to mention here that in very high risk category group of patients, your LDL should be less than 70 and your non-HDL, we said 30 add, so it will be less than 100. But in the extreme risk is only 25 difference, your non-HDL, while the others, high risk, moderate risk, they follow the 30 rule. And I will show you what do I mean by very high risk. So very high risk patients, who those are, especially they come to you to the hospital with an event, or they have a stent, or they have acute myocardial infarction or ACS, or they have severe CKD, or a calculated score above 10. So these are very high risk groups. In the high risk group, they have a total cholesterol above 8, and the GFR is 30 to 59, or a calculated score between 5 to 10. So it's all, I suggest you laminate this and keep it in your clinic, because it tells you which patient is very high or high risk. And as we go down, the risk will become lower. So younger patient, less than 35, diabetes duration, not long, and so forth. But you can see diabetes, this is very important, is a high risk, especially if it is more than 10 years duration. And the majority of our patients form under this umbrella. So patients should be started on moderate intensity therapy because they are high risk. So what does the recommendation? It's easy. So if you are very high risk, your LDL with no doubt should come below 1.4 or 55. If you are high risk, your target should be below 1.8. And the same thing, you should look on non-HDL, provided that your LDL was in target. So just remember these figures, 1.8, 2.4, and 3. And as I said, diabetes is a high-risk condition, so the target should not be 2.5, it should be 1.8. So you can see here the difference with our knowledge and our goals. In 2016, 130 is low, now it's 116 is low. The moderate was 115, now it's 100, the high was 100, now 70, and the very high was 70, now 55. So there has been a major paradigm shift in the way we target our patients. Now also, we like to, there is a treatment now about reduction of triglycerides, because we know triglycerides are also harmful. They also cause inflammatory changes in the endothelium. And that's why these medications came to play part. And the REDUCE-IT trial, which was published, is actually incorporated more than 8,000 patients, and they used just eicosapentaethyl acid, 2 grams twice a day, and they targeted these patients with cardiovascular disease. 70% had an event, and 30% had diabetes, some risk factor, and they followed them for 4.9 years. And the primary outcome, the hazard ratio was 0.75. So there was about 15% relative risk reduction. Now I put here that it's a costly medication, not very cheap. It costs about $900 per month. And some patients reacted with some atrial fibrillation and some evidence of GIT bleed. So that was a REDUCE-IT trial. And this is the forest plot analysis of it. Now, just to let you know, when we treat hypertriglyceridemia, if the level is below 500, the aim is to prevent you from having cardiovascular disease as a first point. When your triglycerides get above 500, the aim is also to reduce the risk of acute pancreatitis. So imagine you are driving on a highway, okay, and the speed limit is 55 kilometers per hour. Now, it doesn't matter if the driver is diabetic, has chronic coronary artery disease, CKD, or peripheral or CABG. The risk has to be 55 and below. So it doesn't matter what type of diagnosis like we think in the previous years, but now we aim for the high risk of the driver and the LDL level. So statins are very popular. They are not automatic. It requires careful clinician-patient discussion, and that's how they work. They block this enzyme here, HMG co-reductase. And by reducing cholesterol, you overexpress the protease enzymes, leading to overexpression of your LDL receptors. So the radars on the road from Abu Dhabi to Dubai, the radars will increase. So if you just speed, they will catch you. So this is the same principle. And the reason I circle this, because there are molecules of statins that have stronger bonding than others and more affinity. Let me give you an example. Rosuvastatin has some bonding more powerful than atorvastatin. Both drugs are very good, but just to explain to you the biomechanics. So statins and CKD, very important. I highlighted this in this slide. So it's safe to use atorvastatin and fluvastatin in patients with significant chronic kidney disease. Also pravastatin can be used as well. And the discussion points you want to discuss with your patients tomorrow is that you estimate the risk, review the potential of benefit and any adverse effects. And also we should respect what is called the patient's preferences. And this is the LDL. So the high potency reduce your LDL more than 50, and they are represented by atorva 4080 and rasuva 2040. LDL moderate intensity 30 to 50, and you have atorvastatin and rosuvastatin at a lower dose, and with the other medications here. Low intensity, we seldom use, but sometimes if the patient have side effects, then you have to reduce the dose and then desensitize them. So what is next? So when you started them at therapy, you should do liver functions at the baseline is a must, and then 12 weeks after, until symptomatic. And you assess adherence to therapy and the response, and you monitor any adverse effect and screen for diabetes. Now we know statins can increase your risk of diabetes, particularly if you have pre-diabetes or impaired glucose tolerance. But actually, the benefit outweighs the risk. Now, some patients ask me about grapefruit juice. They said, are we allowed to drink grapefruit juice with our statins? Yes. If you drink 1 glass of grapefruit juice per day, that will not inhibit your CYP3A4 in the liver, and you don't build up statins in your circulation, but you cannot drink the jar. So as I mentioned earlier, that atherosclerosis is a very dangerous condition, and we should be looking at the atherogenic profile. So you can see here the different molecular size of LDL molecules, Lp(a), intermediate density, and VLDL. So these are all atherogenic particles, and our aim is to treat. So let me give you an example here. So if a twins brothers, hypothetical example, patient A and B, both of them has LDL less than 100, but actually patient B had an event, Y, and the other one didn't get an event, because this guy here on the right has a small, dense LDL particles that are highly atherogenic, small in size, able to penetrate your endothelium, while the large buoyant LDL particles are a bit less atherogenic, and that's why the difference is important. And here you can see the fractionation of the different molecules, L1 and L2 and L3. Now, I just want to talk a little bit about Mr. Lp(a). This is very interesting. So you can see here there is a disulfide bridge bond between this tail, which is Lp(a), attached to the LDL molecules. Now, this tail makes it highly atherogenic because it will block the transformation of plasminogen to plasmine, and you get this accumulation of adhesion molecules. So a question comes, should I check my Lp(a)? The answer is, I suggest you check it once in your lifetime, okay? Highly atherogenic Lp(a), and this is the nuclear MRI scan spectroscopy, which can show you the different fractionation of the molecules of LDL size. They also use ion mobility testing, analytical ultracentrifugation, gradient gel electrophoresis, and so forth. Non-statins, I love this drug. It's called cholesterol absorption inhibitor, ezetimibe, trade name Ezetrol. So this guy works on Niemann-Pick-like-1 receptor at the brush border of the intestine and reduce your LDL by 17%. So if you combine it with a statin, it has a dual mechanism of action. And the data are very promising from the IMPROVE-IT trial. When it's combined with simvastatin, the primary endpoint shows significant reduction of, for patients who had ACS, significant reduction of events. So we know that this drug actually offers you huge cardiovascular benefits, and I call it a user-friendly drug because you can use it to any statin. And now also we are lucky because to reduce the burden of combination therapy or separate tablets, it can be combined, it comes ready combined with other statins. Now, metabolic syndrome, most of our patients have the metabolic syndrome, and we call it the atherogenic dyslipidemia. So what do I mean by atherogenic dyslipidemia? So if you examine your patients with diabetes, you will find that they will have high triglycerides, small density L particles, and low HDL, okay? And they have high chylomicrons and triglyceride-rich lipoproteins. So you can see here the dirty atherogenic profile of this dyslipidemia. Now, this is a very interesting slide because there has been a plethora of statin trials being done worldwide, but it does not protect you. It shows it does not protect you 100% from events, despite being on massive statin therapy. So this is what we call residual risk. And meta-analysis of many trials showed that there is a significant residual risk in treated patients. So our duty is to try to minimize the residual risk by targeting the non-HDL, as I mentioned earlier. And this forest plot proves it. So if you see here, the target level is less than 100, with non-HDL more than 130, you get more events with shift to the right. While if your non-HDL comes below 130, actually, you come here on the midline. And that's proof the benefit of targeting non-HDL. So when secondary targets are used, the recommendations, non-HDL below 2.6 and 3.4 in subjects with very high and high risk, respectively. And this I told you before about ApoB and Apo in less than 80 and less than 100 in very high and high risk. And this is, I repeat it here again, I put it, but in the extreme risk, the difference should be only 25 rather than 30. Okay, so you don't have to memorize it. So in your clinic, if you know the LDL target, then the next LDL target should be your non-HDL level. And these are the guidelines. When you are free, you can read it. And because every time I read it, I discover new things. And this here, this graph simplifies it all for you in at a glance. So this is lipid guidelines at a glance. So you can see for very high risk here is 1.8, like for our patients with diabetes, I mentioned. The very high risk for patients, which Dr. Han will touch base with you. Now, I like to mention about treating hypertriglyceridemia. Now we have the fenofibrate, and both trials, the field and the ACCORD trial, they did not show that significant reduction of cardiovascular events, but the post hoc analysis in subspecialty group showed that if the patients have triglycerides more than 2.3 and HDL less than 1.3, then you'll have actually significant reduction, about 27%. And the same with the ACCORD when they do the fraction analysis of the trial. Now, fenofibrate is 15 times lower in causing rhabdomyolysis compared to gemfibrozil, because we know sometimes gemfibrozil the nephrologist use it because if the GFR declines, then you have to stop fenofibrate. So fenofibrate causes less evidence of muscle damage. And this is the same here. So then a non-HDL goal, again, you add 30 and you aim for triglycerides below 150. And in a patient, if you see a patient tomorrow in the clinic and you suspect they can have some sort of familiar or genetic high cholesterolemia, then, or there are red flags, then I advise you the best calculator is to go to the Dutch calculator, and you just actually tick the box here regarding family, clinical, physical examination, LDL and DNA analysis if you have that. And if they score more than 8, then they have definite risk. So I'm not going to dwell on that because that's actually beyond our talk today. But also you have to think about the secondary causes of hypertriglyceridemia, like ruling out hypothyroidism, insulin resistance, obesity, and some medications like beta blockers. And this is, so initially, if you want to lower your triglycerides, you should use a statin to target the LDL, and statins also reduce your triglycerides before adding another therapy. So these are the different classes. Niacin is used in the US more than usually here in this part of the world. So what are the side effects of statins? They can present with different cohort of symptoms, pain, tenderness, weakness, and it's highest with the lipophilic statins. Lipophilic statins migrate to the muscles and cause myalgia. But you should do these tests, rule out any secondary cause like hypothyroidism, polymyalgia, and vitamin D deficiency. So you stop the drug, wait a couple of months, and restart with a lower dose, or you can use a new statin. So this is called SAM, or statin-associated myalgia. So this is a lady I had. She's diabetic. She has COPD, mixed hyperlipidemia, and she was on Torva 20 and ezetimibe 10 milligrams. She's hypertensive, on amlodipine and valsartan. She's on metformin, vildagliptin, and she saw the cardiologist, and she has tests for chest discomfort, and she had a plaque in the left anterior descending artery. And these are her results. They were all normal. Even her HbA1c was fantastic, 5.8. But if you look here at the total cholesterol, the LDL came down after being on a statin, ezetrol, and PCSK9 inhibitor. So you can see here the dramatic reduction of her LDL. She is a very high risk, and she was intensified on this treatment correctly. And you can see the dip down on your LDL level. And surprisingly, her ECG was actually not that dramatic. So a normal ECG does not rule out a significant cardiovascular disease. And PCSK9 works in a fabulous way, because PCSK9, the more you have PCSK9, it means the higher cholesterol in your system. And they are recycled about 150 times, and then they degraded by endocytosis. So by genius technology, we have these PCSK9 inhibitors, and they prevent the degradation of, will reduce the process of endocytosis, and will lead to overexpression of your LDL receptors, which lead to lowering your cholesterol. So the PCSK9 is very, very useful in some subgroups, like those with multivessel CAD, polyvascular disease, like the lady I showed you with big atheroma and atherogenic, very high Lp(a). So these very high risk group with LDL not controlled, I think you can add them. I'll move to the last part of my talk about the effect of lipid lowering therapy. You can see here a rash, and we don't use, this is niacin flush. It's used more in the United States. It can cause discomfort, and it can actually last 4 to 5 days after stopping the medication. These are xanthomas, actually. You can get nasty looking xanthoma for patients with familial hypercholesterolemia, and it's worth examining the patients in high suspicious cases. This is a tubulo eruptive xanthoma, so it's always sometimes difficult to examine the patient. If it's a female, ask the patient if they have unusual rash, and so forth. And this is arcus senilis, so it's always good to look at the eye of the patient. And you have xanthelasma as well at the corner of the eyes. Sometimes they are not related to cholesterol, but they are local fat deposits, and they can be removed by cosmetic surgery. These are tuberous xanthomas, similar to rheumatoid nodules, very big ones. And this is lipemia retinalis in patients with very high lipid profile. And this 55-year-old had lipemia retinalis, had a serum cholesterol of more than 1,000, and his triglycerides were 15 plus 100. And this is the serum, lipemic serum. Sometimes I have to go and bring the serum of a patient who refused to take treatment for his lipids. So I brought him the lipemic serum, and when he saw that, he convinced that he should be on treatment. So sometimes using of the fear tactics is beneficial while explaining the merits and benefits of achieving good control. So sometimes in severe cases, whatever you do, you cannot get to the level like familial homozygous hypercholesterolemia. You have to go to this heparin-induced extracorporeal LDL apheresis, and you can see here the lipemic plasma using heparin molecules. And this is what we call fish eye disease due to LCAT deficiency. You remember I showed you the slide about lecithin acyltransferase, which will help the transfer of cholesterol esters from the endothelium to your HDL. So these patients, they deposit triglycerides in their lens and they get corneal opacity. They also have hemolytic anemia and premature atherosclerotic disease. This is Tangier's disease, which is actually a defect. They have very low HDL, so a defect in the production of HDL, so it's genetic. But these patients, they don't have atherosclerotic cardiovascular disease, but they have orange tonsils. So it's a very interesting condition. And this is, of course, you know, the Mona Lisa, the most popular piece of art by Leonardo da Vinci. I'm sure you've all seen that picture before, but I just like to look at the picture more closely. So if you look at the picture more closely, you can see her the corner of the eyes, she has xanthelisma, and she had a probable xanthoma in the right hand. So probably she had some sort of familial hypercholesterolemia at that time. So that's very interesting. About COVID-19, I did do a bit of search, and I found that familial hypercholesterolemia at a higher risk of cardiac complications from COVID-19. So that's why we need to get your LDL as well at a good level. So the final part, the last two slides of my talk, is what's new in the field of lipidology. Now, I'm sure you know that we have atorvastatin combined with ezetimibe in one capsule. So now we have also rosuvastatin coming up combined with ezetimibe. And this is useful because the ACT study actually showed, for example, if you have 5 milligrams of rosuvastatin and you want to add, to escalate the therapy, now some of us will go to 10 milligrams. And that will reduce your risk by 6 to 7% because the rule of 6 will make you reduce your LDL by 6 to 7%. While if you add ezetrol, then you will get actually about 26% reduction from Rasuva 5 milligrams and ezetimibe 10 milligrams. So that's useful to know. We have also this lomitapide is antisense oligonucleotide against the microsomal transfer protein. So I showed you in the first part of the talk, this microsomal transfer protein is a protein in your endoplasmic reticulum inside the liver. And it produces a protein that is a precursor for the formation of ApoB. So this drug, lomitapide, it blocks this protein in formation your ApoB. So they come under capsules, and I heard recently that's been available in KSA, Kuwait, and Qatar for a limited number of patients, but you have to give it with vitamin supplements in order to reduce also triglycerides absorption, because if you block ApoB in the liver, you can end up with fatty liver. So it's used for selected cases that you need to, those with very high ApoB levels. Also at a similar story, mipomersin, antisense oligonucleotide. This is injectable subcutaneous, similar to the above. Now, more recently, we have small interfering RNA. Now, we all know from biophysiology that mRNA is transcribed from your DNA and then is translated to form a protein. Now, this small interfering RNA, marketed as inclisiran, is a new approach to targeting PCSK9, and the data from ORIEL trial were actually good over 18 months and is usually given twice a year. And finally, there is a phase 3 trial, which is antibody to ANGPLT3, which is angiopoietin-like 3, is also monoclonal antibody called evenacumab. So this protein, ANGPLT3, inhibits lipoprotein lipase, which I showed you at the beginning. So lipoprotein lipase is important for us in getting rid of the triglyceride-rich proteins. And initially, they found in mice who have some mutation in the AGFL2, they have less risk of having atherosclerosis, and they have much less cholesterol. So this antibody, by blocking the ANGPL3, then you will have your LP lipoprotein lipase and endolipase starting working again. And there is here, there is a QuickTime video on the New England. You can watch it over 1 minute. And this is the link here for you. So I think we are up to date in lipids, and I'm sure there will be more drugs coming in the future. But as I said, we live in an era that's very useful for us and our patients. So finally, I like to mention that we should not treat figures alone, treat patients' risks too, and please do not leave gaps and treat residual risk, especially the non-HDL. And we have to keep safe from COVID, and we should check our lipids regularly. And I thank you for joining this webinar, and I conclude with a nice picture of my country that I was born in. Is a beautiful city of Baghdad. And thank you very much for listening.
يعطيك العافية دكتور راد. That's a great summary and overview of diagnosis and risk stratification and treatment of lipids. I got a. I hope you hear me.
Yeah, I can hear you, but yeah.
A question here. I have a question. I mean, you showed us different formulas of risk stratification. You know, the Q risk, the atherosclerotic vascular risk, the Reynolds, and so on. But what risk calculator do you think best estimates the risk in our population?
Yeah, I think in my opinion, I find the pooled cohort equation actually gives you a good identification. And if they ask me for another one, I would say the Q risk, because it will give you a better idea about the risk itself. I mean, there are numerous. Also, Dr. Hani may be later on shedding a light when he gives a talk, because they also use another calculator. But I think ultimately they all point up to increased risk. But I find the pooled cohort equation will be a good one to use.
Great. Another question we received from one of the attendees is, he says, in high and very high risk patients, do we need to lower the LP(a) if elevated? If yes, how? So I guess the question is, when do you measure LP(a) and what do you do for it? What do you do with the results?
Yeah, I mean, LP(a) in itself is an aggregate risk factor. So generally, what we try to do is try to lower the LDL value. And the way you measure LP(a), if there is, for example, a premature family of severe atherosclerotic disease, or they continue to get events despite maximum statin therapy, then you measure it. And if it's high, and despite the maximum therapy, including PCSK9 inhibitor, then the only way to lower it is using LDL apheresis.
Okay, yeah. Great. Thanks, Dr. Rad. I think we'll move forward with with the rest of the session, and of course, I mean, if there's any coming questions or discussions, we'll.
Thank you. Thank you very much.
Thank you so much for your talk, and stay with us, please. So we'll move ahead to our next talk, and it's going to be evidence basis for dyslipidemia management guidelines change of the European Society of Cardiology in 2009. So with us is Dr. Hani Sabur, and I don't know if Dr. Hani needs introduction. Dr. Hani Zamil Aziz, have been here in UAE for quite a good time, been in Al Ain and Abu Dhabi, SKMC, and now staff physician in the Heart and Vascular Institute at Cleveland Clinic, Abu Dhabi. Dr. Hani did his medical school in Kuwait and then went to the States, to New York, where he had his residency fellowship and cardiology fellowship. And Dr. Hani, of course, carries a 6 American board certification. So, mashallah alayk, diversity of subspecialties in cardiology, and currently is leading a few studies on in the field of electrophysiology and hyperlipidemia. So, Dr. Hani, please proceed, entertain us with the change in the guidelines.
Thank you very much, Dr. Abdul. I honestly don't deserve this wonderful introduction. We are always students, and trying to learn is really what drives us as well. So I'm gonna start with the main, of course, going to be almost impossible to follow Dr. Raad's brilliant and outstanding presentation, but I'm certainly gonna give it a shot. So here we go. So I think atherosclerosis was described very nicely by Dr. Raad. Our objective is always to prevent events before they happen. So as you see here, this diagram shows you that the end stage of coronary acute coronary syndromes, of course, is myocardial infarction or death. And this is sort of a cartoon of what happened to President Bill Clinton when he was probably in his childhood age. He didn't have any atherosclerosis. By the time he became a senator, with his often known fondness.
Dr. Hani,
yes, sir.
I don't know if you did you share your slides? I can't see it. You know.
Let me just see.
Yeah.
I think Dr. Raad has to unshare.
Yeah, please. Yeah.
Okay.
Okay. Excellent.
All right. Here we go. So this is sort of a cartoon of how atherosclerosis develops in real life. So Bill Clinton is famous for his love of Kentucky Fried Chicken and fried onions when he was the senator for Arkansas. He had no symptoms until actually after he became a president, and actually after he retired, he started to have chest pain and developed occlusive coronary artery disease, had to have a bypass. And of course, fortunately, this was rescued. He didn't actually die from that. So I think it's clear that early detection, as Dr. Raad pointed out, and early treatment saves lives and reduces cardiovascular events. So from carotid intimal medial thickness, IVUS, and events, we really try to impact lipid lowering at the first 4 steps and not the last one. So secondary prevention is a minute after primary prevention, isn't it? You know, people have plaque for many years, and all of a sudden, like like a balloon, it pops and you have an event. So really we have maybe 30 or 40 years of physician and clinical exposure in which we can make this a huge difference. So these high-risk patients often have no symptoms, but once they have coronary artery disease, it really behooves us to prevent a secondary event. And this is actually a very amusing, but probably very realistic approach, where we can see how we can impact patients with cardiovascular disease. In fact, the patients with the highest cardiovascular risk are the ones that you can get the greatest reduction of cardiovascular events. And this is sort of from an accounting course that I took this slide from. It's called Invest in Your Arteries. So if you have cash, you really can't do much in terms of investment and reward. You're not going to do much with it. You're going to get the same amount back. On the other hand, if you have a higher risk patient, a higher risk investment, the more time and effort is spent in the outpatient clinic, the greatest return in reduction of heart attack, stroke, fatal and non-fatal events. So I think it's always important to try and identify the high-risk patient in your clinic. Now, as we said, we're going to go through the guidelines, and these are some really important highlights and points from the updated ESC, European Atherosclerosis Society guideline. Now, if you look at patients in the context of LDL and risk, this is how you can create a table, which they've very nicely done, showing the number needed to treat. So in reality, if you have a patient who gets a 40% absolute risk, so somebody with a prior coronary event and diabetes and smoking and dyslipidemia, and has an LDL of 2.0 or 77, right? Their number needed to treat by lowering their LDL by 60% is only 19, right? Now, if you take the opposite spectrum, a patient with a 10-year risk of 10%, who has an LDL of 2.0, you need to treat 77 patients to drop the LDL by 60% to get to the same relative risk reduction. So it is very valuable to treat patients in this corner, whether their risk is driven by very high LDL or very high risk or both. I think it's very clear that these are the kind of patients that benefit from very intensive LDL lowering. Now, the evidence behind this is not really something that we think about a lot because it's incorporated in the guidelines, but I'm reminding you of this. This is the original Cttc Meta-Analysis, where they took about 100,000 patients with all of the clinical studies. This was the 2005 publication. They've subsequently reviewed it again in 2012. So this is 100,000 patients who underwent lipid-lowering therapies. And starting with an LDL of 5.2 and a cardiovascular risk of about 30%, and with additional clinical studies such as TNT and more intensification of therapy, the higher the dose of the statin, the lower the LDL achieved. So here we're getting about 70 with atorvastatin, 80 in the TNT study, the lower the cardiovascular risk. So it's obvious that this is a linear relationship. And every 39 milligrams per deciliter, 1 millimole drop of LDL produces a linear 20% decrease of cardiovascular events. And sort of this absolute risk reduction is very robust. Here are patients with a 5-year risk of more than 30%. If you lower their LDL by 1 millimole, you get 730 events. If the patients are lowered by 2 millimoles, you reduce by 1,440 events. It's exactly double. The same thing if you have a patient with an intermediate risk between 5 and 10%. If you lower the LDL by 1 millimole, you get 170 events prevented. If you lower it by 2, you double that to 310. The absolute number is, of course, smaller, but the relative number is still 50%, 50%, 50%, 50%. So this 50% rule is very fast and very important if you lower the LDL by the proportion that we just discussed. So this tells us, in fact, in very quick terms, why do we need combination lipid-lowering therapy? Because patients on maximum statins still suffer from cardiovascular events, which are fatal and non-fatal. As Dr. Rad mentioned, the rule of sevens is that if you double the dose of statin, will only lower your LDL by 6% more. So going from 20 to 40 of rosuvastatin, 40 to 80 of atorvastatin isn't going to double your LDL lowering. It's only going to give you a 6 to 7% additional reduction. Therefore, combination and synergy with other agents, combination lipid-lowering therapy is essential. In the TNT study, atorvastatin 80 was used. The LDL achieved was 60, but the event rate was still over 7%, which constitutes residual risk. Now, what is the evidence for more addition and lower is better? Well, I don't know if you've forgotten, but the Improve It study 2014, that's now almost 7 years old, was the key and cornerstone to this new strategy. So in this study, addition of ezetimibe to simvastatin produced a 2% additional absolute risk reduction and approximately 10% relative risk reduction, which was statistically significant. Number needed to treat was 38. And this was addition of ezetimibe to simvastatin, achieving an LDL of 55. So this actually became very clear that LDL is bad and the lower your LDL is better, and it didn't really matter how you lowered it. The magnitude of benefit from LDL lowering is therefore independent of the means by which it is achieved. Now, they went back and looked at the genetics of LDL and lipid metabolism in general. I think this was also mentioned very nicely by Dr. Rad. So in those patients who had a genetic abnormality or benefit, if it were, that lowered their HMG-CoA reductase so that they were like statins, had a 20% lowering per millimole, they actually got a 20% reduction of the risk of cardiovascular events. Those patients who had a genetic abnormality that mimicked ezetimibe in preventing the absorption of LDL from the intestinal brush border, again, a 20% lowering leading to a 20% reduction of cardiovascular events. Those patients who had a natural reduction of the PCSK9 protein, natural lack of production of PCSK9 protein, again, every millimole reduces the cardiovascular risk by 21%. It is exactly identical regardless of whatever genotype is used to lower the LDL. 1 millimole is 20% reduction of cardiovascular events over time. The next thing we've learned from the randomized clinical studies and the genetic studies, of course, is that the benefit of LDL lowering is proportional to the absolute decrease of LDL. And of course, the total benefit is dependent on the absolute risk. If you have a patient with a 30% 5-year risk, thousands of those patients will benefit from an LDL lowering of 65%. On the other hand, if you have a 5% LDL risk, 5-year risk, about 130 patients will benefit. So it is important regardless for the individual patient, but if you look at large numbers of patients, of course, a higher risk population benefits more from more complex and possibly more expensive combination therapy. So how do you start this algorithm? So it's defined by benefit risk group. As Dr. Raad very nicely showed us, that we have to utilize risk assessment, and then we have to comprehensively and thoroughly measure the risk to capture and diagnose all the patients and avoid missing patients who should be screened or tested any further. So in diabetic patients, we know this very well. The diabetologists have been doing this for decades, and we have to copy some of their mechanisms and models. And this is what they do, right? Lifestyle, glycemic control, dyslipidemia, platelet inhibition, and blood pressure control. All of it together, okay? And a multifactorial approach is so important. Now, this is why we have to do risk assessment, because these patients often don't have symptoms until they have their heart attack. So a clever doctor is going to catch this patient and diagnose and treat them before they actually have a myocardial infarction. And the pre-event medical interventions that reduce mortality are going to be very effective. So this is, again, from the ESC guideline, and they have helped us define the risk categories. Now, in diabetes, it's relatively easy. Basically, in diabetics, they are either high risk or very high risk. If the patient has diabetes and does not have any target organ damage, but has any single risk factor, so they're diabetic with hypertension, diabetic with dyslipidemia, diabetic with smoking, diabetic with obesity, done. That's a high-risk patient. So very few diabetics that you see in your clinical practice are anything else. So high risk, that's it. Now, if the diabetic patient has other target organ damage, such as they have proteinuria, some renal insufficiency, so GFR between 30 and 60, any LVH on ECG or echo, retinopathy, nephropathy, neuropathy, cardiovascular disease, or they are hypertensive, dyslipidemic, or smokers, which is the majority, suddenly they become very high risk. And specifically in the new guideline, early onset of type 1 diabetes or duration of type 1 diabetes more than 20 years becomes very high risk. And naturally, the highest of the high risk are patients with diabetes and coronary artery disease. So in summary, patients with diabetes and CVD are at the highest level of risk, which the AACE guidelines call the extreme high risk as well. Now, we said that the benchmark for risk is about 10%. Now, what about this? Look at these patients. How many patients have you seen today who look like this? Diabetes and ASCVD, 40% 10-year risk in spite of being on a statin. How about diabetes and CKD or coronary artery disease and CKD? 40% 10-year risk in spite of statin therapy. What about coronary artery disease and poorly controlled risk factors? So a hypertensive, dyslipidemic, obese, smoker with coronary artery disease, 40% 10-year risk. Familial hyperlipidemia, 40% 10-year risk. How common is this? How many patients have you seen today in your clinic who are on a statin and have a 40% 10-year risk? I could say that a lot of them. So The combination of ASCVD and diabetes is actually in the worst category of risk in all the randomized clinical studies. And obviously, the higher your risk, the higher your benefit, as you saw from my accounting course slide. These patients have the greatest benefit from combination lipid-lowering therapy. So in the Improve It study, which included 100% of patients with coronary artery disease, the diabetic patients had a 5% absolute risk reduction versus 0.6% in non-diabetic patients. In the Fourier and Odyssey outcome studies for PCSK9, 2.7% absolute risk reduction, 1.6% in 3 years for the non-diabetic patients, which isn't to say that non-diabetic patients shouldn't get PCSK9 inhibitor, but the diabetic patients are the worst of the worst, and those are the patients that are very common here, and you need to focus on how to reduce their risk in a very aggressive way. What does the ESC guidelines specifically tell us about those patients? In diabetic patients who are very high risk, so diabetes with cardiovascular complications, diabetes with retinopathy, nephropathy, neuropathy, diabetes with LVH, microalbuminuria, or LVH on ECG or other risk factors. Very common. This is an LDL target of 50% from baseline and 1.4, less than 55. Okay? If the diabetic is high risk, which is a patient that you have thoroughly examined and has none of these other risk features, 50% reduction from baseline and 70 milligrams is accepted, and statins in type 1 diabetics who are high or very high risk, that more than 20 years of duration. How do you assess risk? We've talked about it, but here are the other ones specified in the guidelines. In your diabetic patient, routine assessment of microalbuminuria to identify risk of cardiovascular disease, not just renal disease. Resting ECG in diabetic patients if they have hypertension or suspected CVD, because if they have LVH, automatically they become a very high-risk patient. Carotid ultrasonography and femoral plaque, 2A indication, again, as a risk enhancer in patients with type 2 diabetes. Coronary calcium score also can be recommended in diabetic patients, even if they are asymptomatic. Functional testing with coronary CT or nuclear stress testing can also be considered in asymptomatic diabetic patients. But a calcium score is very quick, no contrast. It takes 3 minutes and gives us, as you'll show some examples now, a very clear assessment of the coronary arteries in these patients. Ankle brachial index can also be done in your diabetic patients on a routine basis, plus detection of carotid or femoral atherosclerosis by CT. One other clinical pearl, very important. How many patients do you see in your clinic complaining of erectile dysfunction who want you to give them a prescription for a PDE5 inhibitor like Viagra? Well, ESC guideline, it's right here. Assessment of cardiovascular risk and CVD signs or symptoms in men with erectile dysfunction. Erectile dysfunction is a critical indicator if diffuse cardiac and vascular atherosclerosis, and therefore equals the presence of ASCVD. So before you give them the prescription for sildenafil, think of what does it mean in terms of their cardiovascular risk and lipid lowering and background treatments. So to make it a little bit more clear, the ESC has gone into tremendous detail about what constitutes subclinical atherosclerosis. In other words, if your patient has this test done, what do you convert them to? You convert them to a very high-risk patient. So this is any patient who has had a heart attack. That's obvious. Prior MI, prior ACS, prior coronary revascularization, or any patient with peripheral artery disease. So if a patient has also done an ultrasound carotid or a coronary angiography without obstruction but significant plaque nevertheless, then they are labeled as very high risk because they have established coronary artery disease. Plus diabetes with target organ damage, such as proteinuria, smoking, hyperlipidemia or hypertension, CKD as well. So I think it's very clear that if you have peripheral vascular disease by imaging or by clinical symptoms, if you have coronary artery disease by clinical criteria or symptoms, or even just by imaging, this puts them into a higher risk category automatically. What about albuminuria? I've mentioned it a few times. It's strange, but albuminuria actually not only is associated with progressive kidney disease, which is obvious, it is general indicator of injury in the systemic circulation. In fact, albuminuria is associated with increased cardiovascular risk and cardiovascular death. So microalbuminuria for most cardiologists should be a marker of not just renal disease, but also cardiovascular disease. So this is the ACC, not the European guideline. And again, it takes the same viewpoint in patients with diabetes. Long duration of diabetes, more than 10 years, albuminuria more than 30, GFR less than 60, retinopathy, neuropathy, and they talk again about ABI, meaning that they are recommending strongly that in diabetic patients, ankle brachial index should be done routinely in the clinic, simple bedside or clinic physical finding that is immediately indicating the presence of atherosclerosis and peripheral artery disease. And what do they recommend here? Again, in patients with diabetes, screening for limb ischemia or peripheral artery disease on a yearly basis with clinical assessment and or ABI measurement. This has a class of evidence 1, and educating patients about diabetes as well as limb ischemia, even if asymptomatic. Very important, an ABI measurement is done in the clinic by a nurse. Check the blood pressure in the arm, check the blood pressure in the foot. It's as simple as that. We're not talking about Doppler, we're not talking about ultrasound, we're just talking about pressure measurement. ABI, this is again from the European American guideline here. Measurement is reasonable in asymptomatic adults with intermediate risk, and abnormal is 0.8 in non-diabetics or 0.9 in diabetics. If it is positive, this patient is now established polyvascular atherosclerosis with and without diabetes, becomes a very high-risk patient automatically. Now, coming to the treatment, which I think is the purpose of this whole series, it is very important to start with statins and prescribe high-intensity statin to the highest tolerated dose, but you don't titrate the statins. This is wrong. You don't start with 10 and 3 months later go to 20 and 3 months later go to 40. There is no such thing in the guidelines. If the patient is very high risk, you have to give them a high-intensity, potent statin, and this means atorvastatin 40 or rosuvastatin 20 to start with. And then, if they don't reach that target within 4 to 6 weeks, which is again recommended in the guidelines, then add ezetimibe. And finally, if they don't achieve that, PCSK9 inhibitor needs to be considered. How do we know this and where does this come from? Again, this is coming directly from the guidelines, okay? We know that a moderate intensity statin on average will take the LDL down by 30%. A high intensity statin, 50%. And as I mentioned at the beginning of the talk, in a high risk or very high risk patient, you have to reduce their LDL by 50% to reach 70, 1.8 in a high risk patient, 50% to reach 55 or 1.4 in a very high risk patient. So already you have to go to high intensity statin, 50%. Then if you know that the patient needs more than that, then you add ezetimibe, which was going to give you 65%. If you do all three, PCSK9 plus high intensity statin plus ezetimibe, 85%. So these are the expected benefits. So I think it's totally useless to use 10 milligrams of atorvastatin or 5 milligrams of rosuvastatin. That's wrong because it's not even mentioned in the guidelines. So summarizing all this is this beautiful graph, and I have a copy of this graph in my clinic. I have it on my desktop in the computer. I have it saved on the phone because you need to use this tool to discuss with the patients and overcome the inertia. If the patient has diabetes target organ damage, diabetes multiple risk factors, or coronary artery disease, or familial hyperlipidemia with Ascvd, they are automatically very high risk. Their target is 50% reduction and an LDL of 55. If they're diabetic without target organ damage, in other words, almost all diabetics, high risk, 50% reduction, and reach a target of 1.8 or 70. I don't see patients who have this score, and I don't see patients who are very low risk, okay? So Really important. These targets are all evidence-based. They are not invented by the people in the guideline committee. The new target of 1.455 comes from the Improve It study. In patients with diabetes and very high risk, target of less than 55. Okay? And patients with just high risk, 1.8 less than 70. This comes from the TNT studies and the CARD studies as well. So evidence-based targets as well as evidence-based therapies. So statins are the first drug of choice. If not achieving the target, LDL has to be checked in 4 to 6 weeks, ezetimibe, and then PCSK9 inhibitors. This is how you work through this, and it has to be done aggressively and frequently. You cannot leave this to chance, and you cannot leave the patient with high LDLs for months and years at a time. So, risk assessment, LDL levels, look at the risk enhancers, subclinical atherosclerosis, ankle brachial index, disease modifiers in diabetes, CKD, microalbuminuria, abnormal ECG, all of that. Drug therapy, define the statin, start the highest potency statin from the beginning. There is no use to slowly up titrate. A 50% reduction is equal to a high intensity statin. Doubling the statin will only give you a 7% additional change. If the LDL goal is reached, fair enough. If not, add ezetimibe. If not, add PCSK9 inhibitor. And these are the high risk, very high risk patients, FH patients, and some of the high-risk patients who don't have FH, for example, diabetics with multiple risk factors. So I'm going to skip the diabetes guidelines because I don't think that's the whole point of this study. Now, the foundation therapy of risk reduction includes, as we mentioned, lipid therapies, blood pressure therapies, antiplatelet therapies, and now we have GLP-1 receptor agonists and SGLT2 inhibitors. And as you see here with lipids, we have statin, ezetimibe, PCSK9, and to address additional triglycerides, as Dr. Rad mentioned, icosapent ethyl and omega-3 are important. So this is actually the ESC summary of guidelines for diabetes and cardiovascular disease. Very important to remember that diabetes has a 3-fold increase in cardiovascular disease, particularly in patients with CKD and comorbidities. Multiple therapies are very important to achieve at the same time, and intensive management of all of the risk factors in diabetes, not just the lipids, but also glycemic control and special diabetes medications. The new guidelines are very important, include 1.4 and 55 in very high risk patients with the use of PCSK9 inhibitors if intensive statin plus ezetimibe doesn't achieve it quickly, and additional things like aspirin and antiplatelet therapies and glucose lowering agents as well. So I think one of the key points then we have to think about is when we treat the patient, we treat the patient as one. Endocrinologists have a very effective round table treatment for these patients, and cardiologists have been focused on specific aspects as well. So if we take the patient and put them in the center, the collaboration between the endocrinologist, cardiologist, and PCP becomes extremely effective to manage all of the aspects of care in the high-risk diabetic patient. And of course, the main objective is, of course, we as cardiologists have to be somewhat involved in the diabetes care a little bit more than we have before. We need to screen patients for diabetes because they come to the cardiology clinic and they most likely have diabetes or pre-diabetes. And we also have to work with the diabetologists and the GPs in order to maximize the benefit and the effectiveness. And I'll stop at this point. I think maybe we'll take some questions.
Sure. Thank you so much, Dr. Hani. I think we can go to, I got a couple of questions here. One of them is, about the combination therapy, and it says, in the acute phase of MI, can we combine, ezetimibe with a high dose statin, or should you just start with the, with the statin only, and then,
Yes. So I think this is a very important point, and this was addressed by some recent studies that actually looked at the use of PCSK9 in the acute phase. So this is actually a recent study that was sponsored by Evolocumab. And what they did was, it's called the EVOPAC study. They had patients with acute coronary syndrome. At the time of discharge, they were given either maximum intensity statin alone or maximum intensity statin with a PCSK9 inhibitor. And they were followed very closely. They were actually getting visits within 3 weeks and then monthly after that. The impact on LDL was tremendous. Remembering that those patients originally came in with LDLs that were around 130. So basically LDL about 2.6, 2.7 or 3, not terribly high LDL. So the impact on the combination therapy from the beginning was really tremendous. They were achieving LDLs of 40 milligrams per deciliter or less than 1 within a month of treatment. And as we know from the old TNT study, the curves for acute myocardial infarction start diverging with very low LDL within 6 months, all right, for ACS particularly. So there's absolutely no reason why you cannot start the highest risk patient, the patient who has an acute myocardial infarction, has approximately a 30% chance of having another reinfarction within the first year if the risk factors are not controlled. So I think there's absolutely a brilliant reason to do that. And of course, if the patient has a very high LDL, starting LDL above 200, you know very well you're not going to get the 50%. You're not going to get with a statin. You're never going to reach 1.4, right? Once you have an acute coronary syndrome, 1.4 is your target. So if you're starting LDL as 200, minus 100 from that, you're still going to get 100. So you need to add ezetimibe and probably need to add PCSK9 from the beginning. The only problem is the insurance regulator in this area, especially, wants you to try all other therapies before PCSK9, which is unreasonable. This is called treat to fail. And I think it doesn't make sense in the very, very high risk patient who has a cardiac event.
So, again, I mean, the question was statin plus ezetimibe in the acute phase. Would you risk stratify, say, you know, I mean, we have a patient who was, who comes with the first acute cardiac event. Would you start him on a statin plus ezetimibe, or would you say keep that regimen or, you know, aggressive regimen to a patient who comes here with a recurrent event? So, is there evidence that risk stratify? I mean, we have all them, like, you know, all patients who comes with an acute event, which let me rephrase the question. So acute patient presents with an acute cardiac event, which of these patients would you go with the combination therapy and which would you go with just a statin?
It's very clear actually from the guideline. You don't have to do additional risk stratification. Already the patient has Ascvd. So the next step is going to determine for me how much LDL I need to lower, okay? If the LDL lowering with a 50% predicted with a high intensity statin is more than 100, easy. If the LDL is above 2 times 55 is the target, yes? 101, 110 is now your visit after 1 month, yes? So if I start with 200, I know I'm never going to get to 55, right? If I start with 130, I may get to 65, right? So it's as simple as that. Once you know
your judgment, Dr. Hani, will depend on the LDL checked during that acute admission.
Correct.
So the LDL is not going to reach the target, which is 55. By the combination and based on the rule that Dr. Raed explained, then you can predict or you can tell which level you're going to achieve.
Yes.
You have to do that math and then decide your regimen or on what kind of combination you're using.
Right. So I mean, we can just take an example. If the patient has an LDL of 190, okay, so it's 4.9. I know that if I give them atorvastatin 40 or rosuvastatin 40, the maximum I'm going to get out of that is an LDL of 90 at the most, okay? That still leaves me 45 points above 55. Even though it's 50%, I'm way off the mark, and 1.4 is the improve it target. And if at the minimum improve it, then I'm gonna add ezetimibe. Now, if I'm still, I know ezetimibe is gonna give me another 15%. So now I'm coming down from 90, 15% of 90 means 75. It's still not enough. I already know that in advance. So I think these are sort of very precise mathematical tools, but I think we have to learn to give ourselves some more precision in these high-risk patients. It's a very nice question. Yeah. Very nice question.
So, I don't know, this question is for both you, Dr. Raed and Dr. Hani. If you are to treat a patient with a statin to prove a failure and move to the PCSK, how long do you spend? Or do you keep your patient? You start a statin. If you know that this patient high risk is going to fail, so you bring him after 2 weeks, 1 month, 3 months.
The guidelines also, the American guidelines are a little bit more explicit on this, but also the European guidelines. The entire effect of statins is seen within 4 weeks. If the patient takes it every day, after 4 weeks, you will see the difference in your LDL, you'll reach your final goal, okay? So in a very high-risk patient, I think we should treat them like the diabetologists when they see a very high-risk diabetic patient. They don't see them every 3 months, they see them more quickly. There's an MDT for uncontrolled diabetic patients. So we should have uncontrolled hyperlipidemia patients come within 4 to 6 weeks and get their LDL. Dr. Raad, also your comments, I'm sure, will be very valuable.
I think I agree with you. I think you titrate the treatment gradually until you reach the target, and you should achieve 50%, and you build the thing gradually. Now there is also, I noted here, Dr. Abdelmajid, there was one question previously about Lp(a). If I may just enlarge on that, if you allow me.
Yeah, please. Yeah, go ahead.
Yeah, I mean, I answered that about Lp(a), and I said sometimes if it doesn't come, it's very high risk, then the only option is LD apheresis. Now, just to let you know, from the National Lipids Association, they stratify Lp(a) as a moderate risk enhancer if it is above than 50 millimoles or 125 milligrams. But unfortunately, even if it is, there is no drug therapy that can dramatically reduce your Lp(a) and or reduce your cardiovascular disease, but is considered as a moderate risk enhancer. And the only treatment is, if it's very high, is LDL apheresis. We'll continue the questions, Dr. Abdelmajid, through you.
I mean, there's a question here talking about if you are to reduce the LDL down to 10. So I have a patient who's on statin, on ezetimibe, and on a PCSK9. He's a very high risk patient for atherosclerotic risk. But at the same time, the LDL is down to 10. I don't know. Do we have an evidence about the safety? I mean, this question, we keep getting it frequently, especially when we get to those levels.
So the Odyssey outcome study, by design, by FDA required design, okay, it wasn't because of they didn't know the safety or not. If the patient reached an LDL less than 15, they had to be down titrated from 150 milligram of alirocumab to 75. If this happened twice, then the active treatment arm was stopped and the patient was put into the placebo, but counted as an intention to treat patient, okay? So unfortunately, what this led to is that there were down titration in the patients who were the most effectively treated with LDL lowering. In the end, when these studies, both Fourier and Odyssey, analyzed the data very carefully, patients with super low LDL did no worse in terms of outcomes. So hard outcomes like intracranial bleeding, new onset of diabetes, dementia, renal failure. Everything was exactly the same as placebo in those group of patients where the LDL was 40, 30, 20, and 10. Unfortunately, because of the study design and the deliberate de-randomization of very low LDLs, we don't actually have, except post hoc analysis, right? But all of the post hoc analysis from the Improve It study, again, they looked at an analysis of patients with LDL well below 40. And the Fourier study looked at specifically, there's a paper that's published on patients with very low LDL, 40 and below. Their outcomes were not only safer than placebo, but efficacy was in fact higher. So it's very clear that the lower your LDL, the better. What do you do in practical terms if your LDL is 10, right? If you get a lab value of LDL is 10. So one thing to remember that the Friedwalder's equation, the calculated LDL does not work at all when the LDL is below 40. The calculation fails. It assumes an LDL above 1, okay? In that case, you have to use the direct LDL particle assay, which is the one that we use in Saha and the one we use in Cleveland and Imperial. If that real number is below 10 and the patient is doing very well with PCSK9 inhibitors, you may consider eliminating the ezetimibe, because all of these studies were on top of statin. Remember this, right? Dr. Rad, I think we have also.
Yes. Yeah, I think the case that I showed earlier about that lady with a normal ECG and a plaque in the coronary artery, she went into triple therapy and her LDL went down very low. And you remember I put a red flag and I phoned you at that day. And actually we had a discussion and we continued. So I think there are more data reassuring us that even your LDL goes low, they are not detrimental. Because there was some stories about cognitive impairment and decline and also disruption of your immune system. But I think everything your immune system did was not affected and there was no cognitive impairment. Right. So, but I agree with Dr. Hani about just knocking out the ezetimibe if needed to do so.
So the question about the safety, you think, those super low LDLs are safe based on the analysis that we got from the Odyssey and others. Another question.
Personally, to have a very super low LDL, because we know that remodeling actually of the vessels occurs when your LDL actually is in this super low range.
And can I just add one more comment? Going back to the pathogenesis of atherosclerosis that both of us we showed, there is a reversibility stage that you can actually do just before the calcium started to deposit. Once the calcium started to deposit into that skeleton of fibers, then it becomes irreversible. So that's why aggressive early treatment can actually shift the equation from one side to the another.
Excellent. Now, we talked about the high, a combination therapy in the high-risk patients, especially those who present with an acute cardiac event, combining statin plus ezetimibe. But we keep also getting this question about why not go direct to a PCSK? If you do that math calculation, Dr. Hani, you say this patient's LDL is 200. Why not PCSK? I know there's an insurance issue, but is there any other? Is there a studies or any data that's out there that starts direct to the PCSK?
So that's a very nice question. I'm showing this slide here. I don't know if it's visible or not. I just saw it here. Here, this is actually an analysis from the Voyager studies and the Jupiter study as well. So this is one of the largest studies in primary prevention, as you know. And look at this. This is the response to a high-intensity statin, okay? So they took the same dose, and there are some people who had no reduction and an increase. This is the minority. The majority of people sit here. So they had a reduction, which was about 50%. And some very rare patients had a reduction of almost 80%, right? But the bulk of the population sits here. The vast majority of the reductions get a 50% reduction or more. And therefore, if you know upfront that you're going to get 50% reduction in the majority of the population, the minority are going to drop to much lower than that. Some of them are going to get 30% because of genetic variation and family history. You have to use the risk to tell you how fast you want to drop to that number, okay? So it's not just the number, it's the number and the risk. And then you give yourself the opportunity with the high intensity statin. And within 4 weeks, and this is what I said, and this is stated very clearly in the guideline, 4 to 6 weeks is the maximum you need to do on the high intensity statin. Wallahi, if they're the lucky people who get the 70% reduction, fantastic. Give them a hug and let them go. But the majority of patients don't do that. The majority of patients, the other 50%, don't get more than a 50% reduction, right?
Right. I think you're answering the question, one of the question or the comments here, or sometimes you can't predict the response to high intensity statins. Some patients respond very well and reach the targets, others don't. Another question, which I think the risk calculator probably will help this colleague to answer his question. What he's saying is a middle-aged person with a blood pressure less than 160 over 100 without other risk factors, what's the optimal LDL?
Okay, so
middle-age with
Dr. Rad,
yeah, so hypertension is aggregate risk factor, but one factor per se doesn't make a decision. So you have to stratify all the risk factors: the age, history of smoking, family history, presence of diabetes. So you have to take these collectively, and then you will end up with the proper risk calculation, and then you will decide. So remember, here we treat the risk aggregation. So that's been the paradigm shift in our management of patients. When I remember when I was a house officer, we just had a hypertension, you treat the hypertension. Now we don't treat the hypertension, but you have to address all the other risk factors collectively. As Dr. Hani said, in this nice multidisciplinary team approach, putting the patient in the center. And just to give you an example, me and Dr. Hani, we always communicate using the best non-invasive tool, which is the phone. We always phone each other about mutual patients. And that's, I think, the way forward. We should communicate more than before. So I think, yes, the answer is risk estimation.
Absolutely.
Right. And I think this
Dr. Majid, I think the key point here is that you have to look further beyond the blood pressure and the cholesterol. So for our colleague here, get an ECG, look at the urine microalbumin, look at the HbA1c. Do you know if the patient's pre-diabetic? What is their waist circumference? What is their neck circumference, right? What is their BMI? All of these are additional things that we have to do as clinicians. It's not enough just to get a number and say the patient's fine. It's not.
Yeah, so it's not, I mean, I think one of the objectives of such a session and such lectures is to, to send the message of that, that there's no magic numbers that you're just going to fix or that's going to help you treat your patients. It's you have to evaluate your patient proper. You have the calculators that are going to help you estimate the risk, but there is other factors that you just need to look at the details and don't base your decision just simply on the numbers. You have to look at at the whole risk and then decide what is the right approach to your patient. I don't know, Dr. Hani, do you have a case, or should
yes,
we go?
I do.
Okay, why don't we go with the case and then we'll go back.
The discussion is very interesting, actually. I think the case is becoming all right.
Well, that's I think that's I mean, most of the lessons I learned from there.
Here we go. Okay. So this is actually a cardio-diabetes case, and I just really wanted to use this case exactly what Dr. Rad mentioned. I have the privilege of working at the diabetes center, and it's literally a 1 second, pick up the phone, we get this brainstorming and really a collaboration of ideas that help the patients tremendously. So this is a real patient, actually from work, basically seen both at Cleveland Clinic and Imperial. So he's a 69-year-old man, UAE national, who has type 2 diabetes for 10 years, which he manages with diet and metformin. Non-smoker, myocardial infarction 1 year ago, was actually seeing some of the colleagues in one of the Northern Emirates, hospitalized for heart failure, A1C 9.2%, LDL 99, with a blood pressure of 138/88, metformin and rosuvastatin 80 on aspirin, okay? How would you characterize this patient's cardiovascular risk? I would say this patient's cardiovascular risk is sky high. It's astronomically high because he actually not only has had an event, he has heart failure, and he has dyslipidemia and diabetes. Now, one of the important things when the patient came to our Imperial Diabetes Center, he was told that his LDL is okay, right? One of the biggest problems we had with this patient is to convince him that LDL of 99 is totally unacceptable for his risk profile. And of course, he came to the diabetes center because he was struggling with his sugar, and he knew that the A1C was high, but he was not convinced that the LDL needed to be affected further. So some questions, what other information would be helpful to know, and what else could we do to optimize reduction of his risk of future cardiovascular events? So this is important for the diabetic patients to realize and put this in mind, is that patients can get heart failure with diabetes through both ischemic events and non-ischemic events. So they have, as we said, 3 times the higher risk of cardiovascular disease. So a diabetic with CVD, as we mentioned, has a 40% 10-year risk of myocardial infarction, fatal or non-fatal, and stroke compared to another patient, even on a high-intensity statin, as we saw in this patient. So type 2 diabetics can get heart failure due to MI, and they can also get diabetes with heart failure due to inflammatory effects on the myocardium and fibrosis. So it's mediated by atherosclerosis and independent of atherosclerosis. So you actually have to take this patient as a whole, isn't it? What are the important clinical considerations? So unlike our other colleagues, we took this patient into a team approach with the endocrinologist and the general practitioner and the dietitian and myself and everything. So we looked at these things in detail, and they're very basic things, but very important. Height, weight, BMI, waist circumference. Waist circumference and BMI increase your cardiovascular risk by 40%. What is his ejection fraction? Increases the risk of sudden death. What is his NT-proBNP? What is his New York Heart Association functional class? What about coronary artery disease? Does he have left bundle branch block on the ECG? Does he have diabetic kidney disease, microalbuminuria, or impaired GFR? All of these are very simple physical findings: an echo, a BNP, an ECG, GFR, and microalbuminuria. Very basic investigations can lead to a tremendous difference in the patient's survival. Now, really important to realize is that patients with type 2 diabetes, even when you control their blood pressure, their A1C, their LDL, and albuminuria and smoking, they still have a 45% risk of heart failure in spite of actual risk factor modification, because we have to also address the underlying heart failure substrate that occurs in diabetics. So there's a 45% increase in heart failure in spite of all risk factors being controlled. And this is a massive registry that had about 270,000 patients. What is the treatment this patient is getting? So I mentioned that the patient's on rosuvastatin 40, but what else? Is on bisoprolol 10, is on valsartan sacubitril 200, is on spironolactone 25, and getting alternate days of furosemide, low dose of furosemide. Now, in terms of the lifestyle management, this is why we have to look at weight, height, BMI, and waist circumference. Actually, believe it or not, lifestyle management is the foundation of cardiovascular risk reduction, because this is what the patient has to do for the rest of their life. And it's very important to know what diet are they on. Are they taking, in addition to metformin, how are they reducing their weight? How are they reducing their fat intake? How are they reducing their sugar intake? What is their physical activity routine? How many times have we had time in our clinic to go into this detail? I tell you, we don't. Honestly, we don't. We have to depend on our dietitians and our exercise program to help us do this. So a structured cardiac rehab program is very important, right? This is a post-MI patient with heart failure and diabetes. So this patient will actually benefit from multiple sessions over 3 to 6 months with a lifestyle interventionist. This would be a registered dietitian and an exercise physiologist or a cardiac rehabilitation physical therapist to tailor the diet and physical activity, guidance to follow a DASH pattern diet and intensity of activity to 30 to 40 minutes, 3 to 4 days a week is actually recommended by the ACC/AHA management lifestyle management guideline. Resistance training is also recommended because of type 2 diabetes. Now, cardiac patients after cardiac events often do not get enrolled in a cardiac rehab, but I think it's very important. There's a huge evidence base that cardiac rehab results in reduction in hospital readmissions, improves outcomes. Unfortunately, few of us take advantage or even aware of these referrals for lifestyle intervention. And there's many different academies and societies that help us, as well as the cardiac rehab programs that are well established in SKMC and in Sharwood, I'm sure, and in Tawam and Cleveland. So very important to realize this is a fundamental aspect that we often neglect. Now, what about the patient's other medications? So look at the medical therapy carefully. So we need to add a second agent. The patient's on metformin, as we said, the A1C is 9.2. So it's not ideal. He has heart failure and coronary heart disease and a prior MI. So both the ESC and the ACC and the ADA recommend the second agent of proven cardiovascular benefit in diabetes when they have ASCVD, heart failure, and CKD, in addition to diabetes. So SGLT2 inhibitor, and we have here dapagliflozin, as well as empagliflozin, have an FDA indication for reduction of heart failure. Also, the GLP-1 receptor agonist, liraglutide and dulaglutide, have an indication for cardiovascular disease risk reduction in diabetics with ASCVD. So a few more tricks now for the cardiologist to learn, and a few more incentives for the diabetologist to find this patient with CKD and CVD and put them on these disease-modifying therapies. Now, it's really important to realize that this is a class effect. SGLT2 inhibitors prevent heart failure in type 2 diabetics in ASCVD in almost every one of the clinical studies, EMPA-REG, CANVAS, and DECLARE, in patients with multiple risk factors, with established CVD. And it's really important to realize that these drugs are actually saving lives in this way. In terms of the effect on MACE, which is fatal and non-fatal stroke and MI, actually, this was seen only in the EMPA-REG outcome study, and therefore is reduced in its impact. But again, heart failure is a very important outcome. So for prevention and treatment of recurrent heart failure, this patient with type 2 diabetes, ASCVD, and heart failure, and SGLT2 inhibitor is probably the preferred second agent. We have seen that dapagliflozin reduces heart failure hospitalization by 30% in the DAPA-HF study. There's an 18% reduction in CV death and all-cause mortality and total hospitalization by 25%. So very important, once you pick up on a patient like this, the A1C should be one of the drivers, but the presence of CVD and heart failure should be a very important risk factor as well. So we've seen that the SGLT2 inhibitors also reduce all-cause mortality and heart failure, particularly with the DAPA-HF study. And liraglutide in the LEADER study reduced 13% the composite endpoint and cardiovascular death by 22% with no difference in heart failure. So let's see. Now, we also want to control multiple risk factors simultaneously and early. So the importance of simultaneous multiple risk factor control in a super high risk patient with diabetes and ASCVD cannot be understated. Now, we have data from the Barry 2D study, and this is how it summarizes. So in those patients with only 0 to 2 risk factor control, with no smoking, non-HDLC 130, triglycerides less than 150, blood pressure 130 over 100 and over 180, and a glycohemoglobin of less than 7, there was a 2-fold higher risk of death and a 1.7 time higher risk of cardiovascular events compared to those with 4 to 6 risk factors controlled. So that's really, really astounding. If you only control 2 out of these risk factors compared to 4 out of 6 risk factors, you can change the mortality of these patients by almost double. So I think it's clear to me, looking at this data, that in the ASCVD diabetic patient, you really have to address every one of these risk factors simultaneously, aggressively, and with a very long adherence and persistence. Additionally, we have older data from the STENO2 study that they now showed the 20-year follow-up of the STENO2 study. Those patients with type 2 diabetes but did not have CVD at baseline, the survival advantage extends over 21 years. This is the 13-year analysis was published several years ago. And if you pool all of these studies together with 2,000 patients with type 2 diabetes and no CVD, a 60% lowering of future cardiovascular events at 10 years if they target all 3 parameters, A1C, LDL, and blood pressure, compared to those who did not have targets for either. So it impacts hard clinical endpoints if you miss any of these parameters and then some. So for this patient, the patient's LDL, the rosuvastatin was already 40, and the LDL was 99. So according to the ESC 2009 guideline and the ACC 2018 guideline, addition of non-statin, including ezetimibe and PCSK9 inhibitor, because the LDL is not 50% or remains above 50 in spite of maximum statin use. Now, I don't know what his starting LDL was when he had his first heart attack, but I know that today in my clinic, his LDL is 99. And I know for him, we need a minimum of less than 55 milligrams per deciliter to reduce cardiovascular events. And remember, the endocrinology community has been very aggressive about multiple risk factor prevention. And one of the most advanced guidelines, the AACE guideline, as well as the ESC guideline, define this extreme risk or very high risk category where the LDL target is less than 55. So the PCSK9 inhibitor, such as alirocumab or evolocumab, would be recommended as an additional lipid-lowering agent, along with high-intensity statin and ezetimibe in this patient with Ascvd and comorbidities. And it's really important to know that both FOURIER and Odyssey outcome studies showed similar Ascvd risk reduction in patients with and without diabetes, where the absolute risk reduction, the greatest risk reduction, was seen in the diabetic patient, post-MI patient like ours. Okay? And the number needed to treat was much, much lower and much more favorable in those with Ascvd and diabetes. So this is the comprehensive treatment plan. So a DASH diet and 30 to 40 minutes of moderate activity, refer to cardiac rehab and the lifestyle interventionist, and they do this over 12 weeks so the patient learns some lessons for home. Simultaneous multiple risk factor control, prescribed dapagliflozin or empagliflozin to reduce A1C and risk of heart failure, hospitalization, and mortality. The LDL target is based on the treated LDL level in the Improve It arm. He's unlikely to reach 55 with ezetimibe alone. As we said, ezetimibe will lower an additional 15%. So from 99, that means they're going to get to 85, and that's not good enough. So combination of statin plus ezetimibe plus PCSK9 inhibitor for LDL. And also we need to target a blood pressure of less than 130/80 to reduce risk of cardiovascular disease, particularly stroke. Now, the blood pressure issue is a little bit different between the European and the American guidelines, but I think we can say that the SPRINT study did not enroll diabetic patients, but still in a patient with multiple risk factors, heart failure and coronary artery disease, a target of 130/80 due to comorbidities is very, very relevant. Unfortunately, the ADA still retains a target of 140/90 for these patients, but I think we need to take the most aggressive guideline that helps us support risk reduction in these patients. Now, one of the important things was in the ACCORD study, and those patients had a difference with a blood pressure of 120/80 versus 140/90. There was a reduction in stroke. And in the SPRINT study, they didn't enroll diabetic patients. But this patient with a very high risk of heart failure, very high risk of stroke, very high risk of cardiovascular events would certainly benefit from an blood pressure target of 130/80 if tolerated. So in summary, this is again, summary of the treatment plan. Cardiac rehab, diet, and exercise. The patient has to live with this their whole life. Addition of SGLT2 inhibitor, lowering the LDL with combination therapy, statin, ezetimibe, and PCSK9, addressing the blood pressure target as well as the weight and the diabetes and hypertension all at the same time.
Great, Hani, very insightful case. Talking about the rehab, unfortunately, I deal with a lot of high-risk patients, and one of the things still as a community, we don't have a lot of access to the very comprehensive rehabilitation or cardiac rehabilitation for our patients. What's your advice for a patient who does not have that access, to a cardiac rehab where all the risk factors can be addressed by a multidisciplinary team? I know you have that opportunity, maybe with Dr. Raed, but for a lot of cardiologists and a lot of primary healthcare providers, either here in UAE or in other places, I don't know if we have people who comes from other countries.
So I think we have to do something about how frequently we see the patients. For some reason, it's been written in our policies that we see patients every 3 months. This is nonsense. This is because of convenience and prescription guides. We can see the patients every month. Why not? What's the prevent us? In the heart failure clinic, we see the patient 7 days after discharge and then monthly until titration or stability is achieved. There's nothing to say that the Ascvd patient is any less stable. Of course, they're more unstable in the first year. The risk of myocardial infarction in the first year is incredibly high. So why not see them every month in order to complement these physical activities that sometimes we don't have? So let's see them in 1 month, look at their A1C, look at their blood pressure, look at their LDL, not at target, up titrate or adjust, add the second agent, add the PCSK9, check them again in a month. Again, collaborate closely with the endocrinologist, make sure that we're on the right disease-modifying therapies as we did here. And then you can also tell the patient, look, buddy, you got to go and exercise. If you do exercise, you'll not only lose weight, you're not going to die. You're going to have lower risk of myocardial infarction. I think we need to expand these secondary services, but as physicians, we shouldn't get stuck in this, see the patient every 3 months. This is an invention that was coming from the insurance companies, not based on evidence and not based on guidelines.
I agree. So you need to keep your eyes on the patient. So if you don't have that option of, of having the patient to be treated in a multidiscipline, then you need to closely monitor them and reassess their risk factors. One of the frequent questions still, it's about the calculators in the different populations. And I have a question on the using the risk calculators in the young, young patients, the risk calculator in pre-diabetic. I don't know, Dr. Raad, if you want to take that. Or
I think I answered that question. I don't know, Dr. Hani, do you use any
special? Have any insight on?
Yes. So actually, our colleague Dr. Wael Mohammed published this with the doctors in UAE University. They looked at a very large database from SKMC, and they looked at the validation of WHO, pooled risk equation, ACC, Euroscore, Framingham. It's amazing. In our country, only 50% concordance. You could toss a coin and get the score. So the scores in this population are non-validated and primarily not helpful. They underestimate risk. And if you look at all of the calculators, none of them are allowed to calculate risk less than 40 years. ACC, if you try to calculate risk less than 40, it will tell you, I cannot give you the 10-year risk. I can only give you lifetime risk. So as Dr. Raad mentioned, and I think we highlighted this, for these patients, you have to do a detailed personal risk assessment. Look at the risk enhancers, family history, South Asian descent. Patients with South Asia are mentioned in the guidelines as having increased risk. Presence of CKD, abnormalities in metabolism, hyperlipidemia.
So, Hani, you think if the calculator gives me a risk, usually it's underestimation?
Yes. It never overestimates.
The risk of the patient would be higher than what the calculators would give you.
Absolutely.
That's interesting.
It's fake, and it gives a false sense of security, and it's really dangerous because we have seen patients.
That's the point.
Yep. The computer is often wrong, and we have to learn this. In the lab, it's often wrong. One of the things that the patients come and tell us, Doctor, but on the app now, it says my LDL is normal. And you look, and the LDL is 120. How is it normal? It's not normal. It is not in your risk category range. So also, one of the recommendations we've had, and I think it was done in Saha and Cleveland and also Imperial, is we no longer give a normal range. We say if your risk is high, your target LDL is 55. So this is in the normal range table. So when the patient looks at it, they don't wonder, what is your doctor saying? Because patients believe computers more than doctors. Isn't that right?
That's right. Can I intervene, Dr. Abdel Majid, Dr. Hani?
Go ahead.
I think before the COVID, we used to have in our center very useful Sunday meetings where we have a multidisciplinary approach. We discuss the guidelines and the relevant topics to our practice. And one of the areas that came to our mind was about the LDL targets, because still the ADA put LDL as 2.56 as the right level for our patients, while we are up to date with the guidelines. And now, although it's on the computer, it says 2.5, it doesn't give you a red light on the figure. But I think our physicians, we should actually cascade this information to our colleagues and to our patients, saying that 2.5 is not, because diabetes is a high risk. And actually, regardless of the calculator, I'll tell you, I mean, I have a strong working relation with Dr. Hani and equally with my colleagues, the nephrologist, because once I see microalbuminuria, it's a red flag to intensify the treatment. And it's to start with aggressive therapy for patients, because patients with CKD die of myocardial infarction.
Right.
So I think we have to take that, not only depending on calculators, but just stratifying the other risk factors.
Thanks,
sorry, I cannot.
Rad, yeah.
Yeah, sorry.
Thank you. I kept learning every day. I mean, this is the numbers are important. That's where we learn. If it comes to dyslipidemia, or it's hypertension, or it's diabetes. But also more important is assessing your patient, taking care of the patient. Risk stratifying them. And working with your colleagues, if you're a cardiologist, with the diabetologist, with the nephrologist, to have a better understanding of the atherosclerotic risk.
And also, there is also, Dr. Abdelmajid, before I always would like to mention this point before I forget it, is unfortunately our consultation should not be monotonous, like just sitting and talking to the patients. I think we should be more proactive in showing them figures, pictures, pictorial images, or even a short video. Or like, for example, in my clinic, I have a flip chart that I can show the patients, and graphs like the CKD patient, the GFR, HbA1c, because pictures and graphs will be retained in their memory more than when you tell them verbally. Because once they leave the clinic, they forget 50% of the information given to them during the consultation.
Definitely. I mean, authoritarian or, giving information or giving orders to the patient. Now we're moving towards more engaging the patients into their care. And the way to engage them is to, make them understand that risk. We know that risk sometimes. I mean, we spend time to assess that risk, but I think, to get them to understand that risk, as you showed, say, in the graphs, or the one Dr. Hani also showed us, the one in the guidelines, those are very important tools to help the patient understand where's their positions when it comes to the risk of atherosclerosis. I think we're crossing the timeline here. We're already 3 minutes after 9. I would like to thank you, Dr. Rad and Dr. Hani, for this great lecture and for the interaction. I would like to thank all our attendees, and also apologize from those who we could not get to their questions. We had more questions than the time, and hopefully in the next webinars, these questions will be addressed. Thank you again, and have a good night.